This is the BioCentury Show. Brought to you by the 5th East-West Biopharma Summit in South Korea. In March, explore how to globalize Asia innovation and connect with key players across Asia's innovation arc, from India to China to Japan.
Hello, I'm Steve Usdin, Washington editor of BioCentury, and I'm really happy today to be speaking with Elias Zerhouni, president of OPKO Health and vice chair, co-founder, and chair of Modex Therapeutics. I first met Dr. Zerhouni in 2002, shortly after he became director of NIH. I think that's how most of you probably know him, and stayed in touch as he became head of R&D at Sanofi. Dr. Zerhouni's recently written a book, Disease Knows No Politics. Oop, here it is, which I highly recommend. I learned a great deal from it. So I kind of want to start with something from that book, which is you talk about leaving Algeria and coming to the United States with a couple $100 in your pocket, going to Hopkins, and really living the American dream. You went from an impoverished immigrant to the head of NIH. Would that be possible today?
Oh, that's a great question, Steve. First of all, thank you for having me. I think the straight answer is no. I don't think the same story could evolve today, simply because of the chaos that you're seeing around the ecosystem of biomedical research on multiple angles. I mean, it's challenged from multiple directions, but most importantly, you heard about the H-1B visa and the $100,000 fee that you have to pay. And so in those days, it wasn't really that hostile. It was really welcoming. I mean, people wanted to attract and recruit talent from all over the world and give them a chance. The reason that is important is because we are only 4% of the world population, and we are 25% of the economy of the world. We're 330 million people. Even if you get talent, like 1 in a million talents, you only have 330 of them. China has 1.4 billion people. They got 1,400 of them. And then India has the same amount. There's another 1,400. So we're overwhelmed from the demographic point of view. And on top of it, our system of education for STEM education, science and technology, engineering, is not producing the number of people we need to sustain this economy. And so today, if I was to come like I did when I went to Johns Hopkins, wanting to really advance research in biomedical imaging, it would be almost impossible to do that.
And and that, if you think about it, if you look around at any biopharmaceutical company, if you look around at any research lab in the United States, they're packed with immigrants, people who weren't born in the United States, and certainly the children of immigrants. If we're creating an environment where they're not going to be comfortable coming or even able to come to the United States, where is that going to leave us in 5 years or 10 years?
I mean, the strength of science and technology enterprise is not the money, it's not the facilities, it's the people. And if you really look at the way our top universities have been training the workforce of the talented people that we need, it's been very productive, because in graduate programs right now, over 50% in almost every graduate program is made up of non-US born citizens. And they all want to come here because of the dream. The American dream is something that I lived. I think it's something precious, and we don't want to lose that. But right now, because we have a challenge on federal funding, a challenge on universities have two roles. One is discover new knowledge, but also train the next generation. And right now, you have a lot of discouragement of the next generation. I hear young people saying to me, Elias, why would I want to do this? The success rate at NIH is collapsing to 4% with all the proposals that they're making. What is my chance? What is my chance? I'd rather stay in my country or go to other countries that are more welcoming. And so that's the issue that we have. We have a perfect storm going on right now. with funding being attacked, universities being attacked, biopharma because of pricing issues being attacked, and then at the same time, philanthropy. Philanthropy is a major, major asset because it trains people and it encourages universities to train young people that haven't proven themselves yet, and yet it's being taxed. The 8% tax, people talking to go to 35% tax. Well, that will remove all of the incentive to, in fact, be generous in this country, which is a strength of the United States. And that's reflecting back on biotech investing. So for your audience, it's very important to understand that we are facing also a decrease in commitments and investments in the field of biomedical research and biotech venture formation.
So on that very happy note, I want to move to what you did at NIH and kind of whether you think that there's still unfinished business. So I remember very vividly when I first spoke with you when you were NIH director that one of your big pushes was to move NIH more into the translational space and to move it into the valley of death that was preventing science from being translated into medicine, really. And you did that. You really it was an inflection point for NIH. And I'm wondering how you kind of assess it looking back now. How far has NIH gone in that direction? How well is it done, leaving aside all the chaos of the moment? And what's your vision for where it should be?
Yeah. I don't want to sound like I'm completely pessimistic. I'm not. Actually, there are some good things that are happening right now. Congress and the appropriation committees of both the House and Senate have not accepted the decrease of the NIH budget. They have maintained actually the budget of the NIH and increased it to some extent. So that's one. I think the other aspect that I think is encouraging is that I talk to people in the administration as well as people who are supportive of President Trump, and they're telling me, look, we don't want to destroy the scientific enterprise of the United States. We wanted to stay number one. Now, when I came to the United States, I thought of two things. One, that it was the best medical research system in the world, and it was the best healthcare system in the world. Fast forward, to go back to your question, the biomedical research system has continued to progress to be actually supreme right now. I mean, we're still number one in the world. The healthcare system, on the other hand, went into the other direction, where it's actually very disappointing because we spend more money than anybody else, and yet at the same time, we don't get the same return, if you will, in the investment. So to go back to your point, when I became an NIH director, there were two things in my mind that were not functioning properly, and that's why I was probably chosen. Number one is the fact that science was changing and the institutes were not. The institutes were created along organs, brain, heart, and so on. Well, the science was going into immunology, which was across the board, and computational biology, which was across the board. And what was happening is that there were gaps that were opening up between what the NIH should do, or should have been doing, and what the institutes were doing. So my role was to really bring the two together and enhance the ability of NIH as a whole to do things that no single institute could do. That's what we call the roadmap for medical research. Part of that was the fact that, the country and the people were expecting results. They were expecting outcomes, and we've delivered. I mean, if you look at the reduction in mortality for heart disease, it's amazing. When I was there, in 1975, we had 1 million people dying a year, 1.3 million exactly of heart disease. Then it is now less than 500,000. Cancer, I mean, there was not a lot of survivorship at the time. Look at where we are today. So that has been good. However, what is not good is the fact that the people are not seeing that as a result, because they're saying, well, you all are getting all this funding and you're all these white-coated, brilliant people, but what I'm seeing is a healthcare system that's not accessible, it's not affordable, and it's opaque, and I feel like I'm taken to the cleaners. You guys are promising X and delivering Y, and that is really the challenge of translating what we know into what the people need. That's the problem we have. And that's why we lose trust in the institutions. And you hear about the loss of trust in science. And though all of that is a side effect of the fact that we've overpromised and underdelivered.
So you talk about trust and you talk about overpromising and underdelivering. I think, one area where a lot of the trust has been lost, and the current leadership at NIH and at FDA it reflects this and has been heavily involved in it, was the whole pandemic experience. And some people, especially in industry, they look at it and they say, well, the companies that developed the mRNA vaccine saved the world. The people who were running FDA and NIH now have a very different opinion of what happened and what should happen going forward. What's your view, looking back on the whole experience now? How did NIH, how did industry perform? Why did we lose the trust that we had, and where are we going?
Well, I tell you what, my view is this, is that number one, we had a lot of missteps because of lack of preparation and an underestimation of the pandemic risk. When I was the NIH director, we worked with the president at the time, President Bush, to define a response after SARS happened. You remember SARS, the first?
I remember, and I remember the blueprint that you created when you were there for.
You remember?
For that.
So we
Yes.
created that, and then we convinced the president and HHS to have with Tony Fauci at the time, to have a response, organized response. The thing what we found, for example, is that testing was the key thing that prevented us from having a pandemic during the first SARS. We knew who had the disease arriving from what airport, and we quarantined them so that it was limited. All of that went by the wayside with the successive administrations. Why? Because then we have H5N1, and people said, oh my God, it's going to be a 2018 pandemic again. I mean, a 1918 pandemic. And that didn't happen. And then we had the H1N1 in 2009. Then we had MERS, in the Middle East, COVID syndrome, COVID disease, and that didn't happen. And then we had Ebola, and then Ebola started and then died off, and then chikungunya, and all of the Zika, and all this.
And so on, yeah.
And people were screaming like, oh my God, this is the big one, this is the big one, this is the big one. So crying wolf too much lessened the hearing of the politicians and the administration, and they disbanded the team. Now, when the real pandemic came, two things happened. One, CDC just screwed up this testing. I mean, there was no, and then FDA compounded the problem by saying no private enterprise should develop a testing for a public health emergency. That was another stupid thing. So we took 2 months, 3 months before we could figure out what was the disease and who was transmitting it, okay? So that was one. Second, when you look at the good side of things, because NIH had invested for 20 years in the biology of the coronavirus, we knew exactly what the sequence was that we needed to use for a vaccine within 48 hours. That was a miracle, because I think people criticize, today, the pandemic response, but the one thing nobody criticizes is the fact that the vaccine saved millions of lives. Even Secretary Kennedy, who was anti-vaccine, said, oh, that was good, that was great. It deserves the Nobel Peace Prize, whatever. But later on, what happened was the confusion between the socioeconomic impact of a pandemic and the pandemic medically got confused, got really complicated. And so stopping schools, for example, having a blanket response for isolation around the whole country, when in fact rural areas didn't have a lot of coronavirus and so on. So those missteps led to a point where people felt the pandemic in a very different way than just having the disease. They felt it, their kids not going to school, them not being able to earn a living. And that basically clashed, the misunderstanding between the medical and the socioeconomic impact of a pandemic is clearly what created a rupture between the medical establishment, the Tony Fauci's and Francis and NIH and the CDC, and the administration itself, which was compounding the issue by creating misinformation about chloroquine and Clorox and all that. So it became a very unfortunate and disorderly thing, which the current leadership like Jay Bhattacharya and so on are saying, when I talk to him, he says, I think he said the early response to the first vaccine was great. But then pushing the boosters on people and pushing the closing of the schools for a long time. But that wasn't an NIH issue. That was really a policy issue, which was not understanding the impact of a pandemic on the socioeconomic and the pain that the people were feeling, which again, you promised me a cure and you're delivering pain. It didn't happen in Sweden, where Sweden said, wait a minute, we can take the pandemic, we can manage the pandemic, but we're not going to close the schools and the companies and all that. So that to me is the crux of the matter. People did not appreciate the relationship between a pandemic and its impact, socioeconomic impact on the people themselves.
Well, I've got a couple of follow-up questions on that, and I want to come back to that. We've got to take a quick break now, and I'll come back and ask you about that. And then I want to switch over to your experience at Sanofi and what you learned heading R&D at one of the biggest pharmaceutical companies in the world.
All right, let's do.
An arc of innovation is emerging across Asia, and Western biopharma leaders are taking note, from cross-border deals to new co's. In March 2026, the 5th BioCentury Bay Helix East-West Biopharma Summit visits South Korea for the first time. Meet the biopharma leaders putting Korea innovation on the global map. Learn why Korea has become a clinical trial and manufacturing hub. Discover if Korea is the next hotspot for new co-formation. Plus meet biopharma innovators from India to Singapore to China and Japan. Register now at biocenturyeastwest.com.
I'm back with Dr. Zerhouni. I want to just one more or two more follow-up questions about COVID, because it's such an important episode in our lives and in the history of the 21st century. The response now to the things that you were mentioning has included the U.S. government abandoning research on mRNA vaccines, a backlash against all vaccines. What are your thoughts about that?
Well, two thoughts. One, the backlash against vaccines is not all related to the pandemic. It existed before, right? The anti-vaccine movement existed even when I was at the NIH. I had a lot of advocates who were against vaccines because of autism, because of thimerosal, mercury in the vaccine. So there's always been an underlying current of anti-vaccine philosophy or ideology or even belief. And so that's one thing that really is underlying our society right now, where again distrust and disinformation really trigger a behavior that actually is not just uninformed people. I mean, if you look at where anti-vax actions are successful, it's really the educated class, and it's not, when you see the breakouts, you see them in California, you see them in Germany, you see them in areas where there is an education, because people really come and say, I don't know the answer. I cannot tell whether my child would be hurt by having all these vaccines. Then you have an accelerant there, which is that the current HHS secretary is against vaccine and has been ideologically against any change of the environment that could trigger a potential negative response, would be foods or vaccines or any intervention. And he has this sort of notion that there is a conspiracy of business, of industry against the people. So you are really seeing a clash of concept, a conceptual clash with different realities being, facing each other right now. I think cooler heads will prevail. I am hopeful, because at the end of the day, we're going to see more breakouts, more, episodes of measles and other diseases. So that would change the people's attention, because I've seen that in the regions where we had measles outbreaks. Then right after the vaccination rates goes way back up again. So that's one. So it's not all the pandemic, that really created that. And then the other thing is obviously what you said. You said, there's a general loss of trust in institutions. I mean, Congress is 6% approval, and on and on. I mean, that there is a different atmosphere in the country because a lot of grievances have not been addressed.
So switching over, you went from NIH, and then you became the head of R&D at Sanofi. What was that transition like? What did you learn about industry that surprised you, having come from an academic environment? Kind of looking back on it, what do you think you accomplished there?
I tell you, it was not an easy transition because for 2 years I worked at the Gates Foundation, for global health. And that's the one thing that you mentioned about how we are. When I was nominated for the NIH directorship, the president said, I'm going to double your budget and I want to stamp out HIV/AIDS. Today, the new NIH director, who I don't envy, but he's a good man trying to do good, is told, we want to cut your budget by 2, and then, by the way, forget about HIV/AIDS. And that is really a very different environment, right? So it took me 2 years because I got pulled in by the CEO at the time, Chris Wiebacher of Sanofi, who asked me to evaluate their R&D. And for me, as an academic and NIH, the industry was the dark side. And I had no idea I would ever be in industry. But when I reviewed the R&D programs of Sanofi and the challenges they were the way they were dealing with it, and how they carefully replicated the science that was coming out of NIH and the universities, I fell in love with the concept of R&D in industry because you can do things there and I'm a translational person, so I said, this is an opportunity for me to really make a difference. And what I did at Sanofi is convince the board that having just a small molecule company was not viable. You needed to really work with the best people to get into biologics. And so we struck a partnership with Regeneron, with George Yancopoulos and Len Schleifer. And I told them, I said, look, the strategy is partner, learn, leapfrog. Those 3 things. And so we partnered, we learned, we created Dupixent, which is one of the bestseller right now, and 13 other products which went through approval, and I learned a tremendous amount at that time because we had 13 that went through, but 18 that failed. So it's not such a bad batting average, 45%, 50% is not bad, but boy, I tell you, it's painful when you spend a lot of money and then you fail completely. But we learned from that. And then I realized that from the point of view of our industry, we needed to accelerate innovation. And my feeling was that we needed to develop new molecular forms of antibodies, multispecifics, and vaccines, multivalent. And there were others that were interesting, but that's what we worked on. And eventually that lab that I created at Sanofi, called the Breakthrough Lab, is what became Modex Therapeutics after I left.
So you also got an exposure while you were at Sanofi to all the issues around drug pricing, and the controversies around them. From your experience there, looking at it now, it's the only thing probably in the biopharma world that's more controversial than COVID. The COVID experience is drug pricing. What are you thinking? What are you thinking about drug pricing? What did you learn about it, and where do you think we need to go?
Well, I tell you, drug pricing is the one thing that's supported by both parties. It's a bipartisan conjunction of interest that says we need to fix that. Now, in my book, I describe actually the dynamics of that. And at one time, I was being asked to justify the drug price by R&D expenditures. And I looked at it, I said, guys, this does not make sense. That's not your problem. Your problem is you have a healthcare system that's gone out of control. And it's gone out of control. Why? Why are we spending this year $5.4 trillion on healthcare, right? When you look at it, and I have looked at it, you realize that if you sell a drug for $100 in Europe, the company gets $90 back. If you sell the same drug for $100 in the US, you get $45 back. So to make the same amount of money, you need to sell the drug for $200. Why is that? Because you have so many middlemen and so many intermediaries inserted in the healthcare system, and they have captured the system. Really, we are living with a problem which is way, way beyond drug pricing. It's the capture of the system by special interests. For example, when I was the dean at Hopkins, I managed all the clinical affairs and the research affairs and so on. I tell you something, I spend 11 to 15% of our funds to fight the insurance companies. And they, on the other hand, were spending 15% to do pre-authorization, denials, and all. And the fundamental contradiction is that providers want to increase their revenue and payers want to decrease the providers' revenues. So you have at the core of our system a conflict, and the pharma companies did exactly the same. So, the PBMs wanted 50%, okay, I doubled the price. And then, oh, by the way, I need more marketing than I do in Europe, so therefore I increase the price. And oh, by the way, I need to finance my R&D. So what happened was a free-for-all, which is out of control. So drug pricing, to me, has to become a more reasonable. There's a lot of free riding from Europe. And at the time, by the way, before I was in industry, I was asked the question, what can we do? And at the end of the day, I said, listen, it's a trade policy. The trade negotiator should really force the other countries to support drug pricing so that we don't have to cover all the costs by the US on the US consumer. But the fact that it happened is related to the dysfunction and fundamental contradictions and tensions of our own healthcare system, which I think needs reform, but no one is interested in reforming it because, Steve, it's a minefield for any politicians to wade into that.
So, it sounds like you have some sympathy for the Trump administration's policies, or at least their rhetoric on most favored nation drug pricing policies. You think that
I do, but I don't think it's wide enough, because let me tell you, when you talk about different pricing between the US and other countries, there are other elements that are much, much bigger. I mean, it's about 3 times the price that we pay here than compared to others, of which half is really intermediaries. That's why the most favored nation, Pfizer, and the companies that have settled have found a way to just basically sell directly to the customer. Because by selling directly to the customer, you can sell it at half price because you don't have the intermediaries, the middlemen to pay. So when you look at it though, an MRI, an MRI costs $3,000, $1,500 to $3,000 here, is $100 to $300 elsewhere. A colonoscopy, you get a colonoscopy in Japan, you go to the airport and there's a clinic next to it, you can get a colonoscopy for $400. How much would you get it? $4,000, 10 times. And ICU stays, $12,000 a day here, $2,000 in Europe. And when I was the head of Sanofi, I learned those differences because I had labs in Germany and France and Japan and China and so on. So there is a structural problem. And that's the problem, is that to just blame drug pricing is not enough. Drug pricing is not going to change the total picture with a cost of healthcare that's going 6-8% a year, when GDP is going 3-4%. So you have to talk numbers, you have to talk data. And yes, it's good that they're taking care of this, but they need to look at the entirety of the system and the fact that you have these extraordinary margins that you're creating. And then at the same time, everybody's losing money, supposedly, right? And so what gives? And so to me, you have to do what I did in my book. I just talked about the fact that distortions are existing across the entire set of services and strategies that we use in healthcare. Like they're using now MAHA for chronic diseases. That's the right thing to do. 80% of our spending is related to chronic diseases. Yet our system is guided towards specialty care, not primary care. So how long is that going to be before we get into controlling, preventing the spend of more advanced diseases to do something better earlier? So that's my point. My point is it's only a partial tweak, band-aid to the problem. It's politically great because both parties are in agreement, but I don't think it's going to be effective in correcting the fundamental issues.
Well, we have about a couple minutes left.
Yeah.
And when we're talking about fundamental issues, in your book, you do have a proposal for how to restructure healthcare in the United States. Let's just talk about that for a few minutes. What's your idea?
I'll tell you what, my idea is that of an NIH director. I traveled the country, and epidemiology is different from state to state to state. If you go to Mississippi, it's completely different than Minnesota. Yet we are one size fits all, managed by a centrally powerful system in Washington, all right? So the first thing is we need to regionalize our healthcare system, getting closer, devolve it to the regions, just like the Federal Reserve has 12 economic regions because the economy is not the same. Healthcare is not the same across the country. So we need to devolve into regions.
And you're talking about that for CMS, for Medicare?
Yeah, for the entire thing. I mean, my view would be the HHS secretary should really have 10 or 12 health regions. And these health regions should be directed by deputy secretaries, however he wants to do it. But you have to sort of say, let the innovation and the decentralization and the disintermediation occur at the region, not centrally with a couple hundred legislators getting together with lobbyists to try to the machinations that in healthcare. So depolitization, regionalization, disintermediation, and innovation. Let me tell you about innovation, if I may. We need more what I call implementation research in healthcare. You need to try something and try another. You cannot. I tried to do this when I was at Hopkins. I had discovered a way of getting a scan of the body in 45 seconds, the total body. And I said, instead of having the test cut up by CPT code, the head, the neck, the face, the thorax, why don't we just do that as soon as the patient gets in, make the data available to doctors when they have a question? Well, the general counsel told me, if you do this, you go to jail because that's fraud and abuse. All right? Then you ask yourself the question, how much do we spend on Medicare, Medicaid? You know how much we spend? About $1.8 trillion a year. Dr. Oz spends more money than the Secretary of War, twice as much. And I ask you the question, how much money does he have to really R&D money to figure out what the best spend is and the implementation of that is to do some research on, is it better to do X or Y?
Very, very, very little.
1 billion.
Yeah.
1 billion. So how can you adjust a 1.7 trillion behemoth of spend with having no radar as to what is the best way to spend? And then they say, well, NIH should do it. I was asked to do that. But the cost is about 25 billion a year. It would have taken the entire NIH budget. So the fact is, we have nothing that is the radar, of how best to spend the money that the American people are giving to healthcare. That's why I'm proposing not a revolution, but a devolution. Back to the people.
Well, thanks. I have to encourage people to read your book to learn more about it because we don't have more time to talk about it today. But I did find it a really illuminating and interesting read, and I think everybody else will also. And thanks again.
Thank you, Steve, and thank you for having me and asking really good questions. Thank you.
Brought to you by the 5th East-West Biopharma Summit in South Korea. In March, explore how to globalize Asia innovation and connect with key players across Asia's innovation arc, from India to China to Japan.